it is lying above the edge, it is grade 3, and if it is lying below the edge of the vestibulum, it is grade 1. That is how you classify according to Thomas classification. So this is most likely grade 2. Right? Now the thing to remember before we start on to management is that the head is not limited to the nucleus. If you will create an arthrogram over here, the head will be this big. There is a thick cartilage which we are unable to see, but we must remember at the back of the mind that this is not the head. This whole of it, this is the head. Right? Which you will see only on creating the arthrogram. What else you cannot see? You cannot see this is the edge of the vestibulum, and the edge of the vestibulum is further deepened by a cartilaginous labrum. Right? Over here the labrum is present here, and the head is lying on the lateral side of the labrum, not on the medial side of it. So when you are trying to reduce this head, what is obstructing? A thick labrum, right, which has never contained the head. Because it has never contained the head, there is not space, it has not created space on the medial side to contain the head. Alright? So when you will create an arthrogram out of it, you will clearly see the horn-like labral shadow, and when you are trying to reduce it, either it will buckle inside and give an unstable reduction, or it will altogether not result in reduction. Alright? So that is why when the child becomes bigger, it is imperative to reduce it by an open method. Even if you are able to achieve a closed reduction, it may be unstable. It is usually unstable. Right? What is the other factor which is obstructing the reduction? One is the labrum, which we already told, and the other one is just imagine over here. This is the capsule. This is the capsular shadow, right? Got it? And the capsular shadow over here is this, and then it constricts over here, and then again, figure of it. So what is obstructing it? What is creating the hourglass? The contracted tendon, the shortened tendon of iliopsoas. So iliopsoas muscle on the normal side is coming from here and getting inserted here. From here, it is not coming straight, it is bending like this. Because head is moving up and iliopsoas is also taking it up, right? So it is hooking it like this. Okay? So until unless you will release this tendon, you will do tenotomy, you will not be able to release this figure of 8 constriction. And once you release this tendon from here, and you are able to put the head inside on the middle side of the labrum, you will not be able to achieve a lasting reduction. You might be able to achieve a reduction, but it will be a reduction which is unstable. It might redistribute. And that is the importance of open reduction. Okay. The other important thing, besides looking at the femur, is vestibulum. In fact, it becomes more important as and when the child grows. What changes are seen in the vestibulum? Dysplastic changes. A shallow vestibulum, a straighter vestibulum is called a dysplastic vestibulum. And because it is congenital, it is a developmental dysplasia. That is why the vestibular development does not happen until unless the hip is contained. Because it receives stimulus to deepen and grow because of the femoral head. If femoral head continues to lie outside, then it will never deepen, it will never remodel, right? So it is most important to reduce this as soon as possible so that vestibular dysplasia gets corrected. Now, vestibular dysplasia gets corrected only when you do an open reduction in a younger child, preferably less than 2 years of age. After 2 years of age, the stimulation is so less or it is so late that vestibulum fails to develop completely. And this can result in a lateral subluxation or a lateral uncoverage. And because of this, due to these reasons, usually even if at the time of open reduction, it's a stable reduction, you will add a vestibular procedure. The other method I told you yesterday, that this head is in valgus and it is anteverted. Anteverted means it is looking towards me. If this is the child, the head is directly looking at me. So you will reduce this head by internal rotation, right? And you will add abduction. Now what happens in adding abduction and internal rotation is that if you do internal rotation, the moment child starts walking, it will external rotate again and it will come out again. With abduction, you must remember that if you are able to reduce a hip in abduction more than 45 degrees, you are going to put vascularity into compromise. You will compromise the vascularity. So earlier there was a tendency to produce extremes of positions to reduce the hip, and this extreme of position was called a frog leg reduction, right? That means 90 degrees of abduction and around 45 degrees of flexion. So this can produce impingement of the vessels, resulting in avascular necrosis. From frog leg we came to human's position. So less abduction and more flexion. So around 90 degrees of flexion, but abduction never more than 45 degrees. Ideally not more than 20 to 30 degrees, but never more than 45 degrees. This is human's position. Now that means that we should not be abducting more than necessary. Because we do not want to abduct more than necessary, we add a varosostomy. We abduct the proximal fragment, but then we bring it back to around 20 to 30 degrees by adding a varosostomy. Am I clear? So that is the principle behind producing a derotationostomy and a varosostomy. Now once you have done this ostomy and the hip is stable, then you will see whether there is any anterior uncoverage or not. When there is anterior uncoverage, even after doing a derotation and varus, then to cover it, what will you have to do? You will have to flex it. Alright? So when the child starts walking, he will not walk on a flexed hip, he will walk in an extended hip. So when the child starts walking, such a child starts walking, he will have persistent anterior uncoverage. When there is persistent lateral or anterior uncoverage, it will result in a persistent vestibular varus, vestibular dysplasia, which will result in unstable hip and a painful hip later on. So in such cases, you must add a vestibular procedure. Now what vestibular procedure? Right? So the vestibular procedures, they can be nominatostomy, there can be acetobuloplasties, and then there are the triple-ostomies. Right? So these are the three basic vestibular procedures we do. The first one is the denominatostomy, which is the famous sarcatostomy, where you create this is antero-inferior iliac spine, and this is the sciatic notch, and you will create ostomy over here, transverse ostomy, and you will redirect or rotate you correct the ostomy over here. It divides the nominate ostomy into, nominate bone into two parts. The one above the ostomy and rest of it below the ostomy. The part which is above the ostomy is articulating with which? With which structure? Above the ostomy? The sacrum. Got it? ये solterostomy करी. ये वाला जो part है, it is articulating with the sacrum, and the part below it is articulating with the symphysis, right? So if you will exert your forces on the proximal fragment, what will happen? Sacroiliac joint will subluxate or dislocate. So that is why in solterostomy you are asked not to give traction to the proximal part. Now what will happen to the distal part? There is a joint over here. So if you will redirect it laterally, it will result in a lateral coverage and in some amount of anterior coverage. Right? So you insert a triangular graft over here, and where is it moving? It is moving at the symphysis place. Now you see, when you are redirecting it, the hinge is far away. So when the hinge is far away, you will be able to produce only small amount of correction. So with Salter osteotomy, you will be able to achieve around 10 to 15 degrees of correction only. If you want more correction, then hinge should be nearer to the deformity. So what are those osteotomies which are nearer to the acetabular dysplasia? The acetobuloplasties. Acetobuloplasties, they redirect the acetabulum. They do not rotate the innominate bone. They redirect the acetabulum. So how do you create that osteotomy? You begin here around 1 centimeter, 1 to 1.5 to 5 centimeters above the anteroinferior iliac spine, and you bring this osteotomy till the triradiate cartilage. You do not violate the sciatic notch, right? And when you will redirect this fragment, you have created this, it's a flap of bone, and when you will redirect it, you will produce redirection of the acetabulum, right? So Salter osteotomy, the acetabuloplasty. Then there are several, modifications of Pemberton acetabuloplasty, right? The Dega osteotomy, the San Diego osteotomy, the Pembersall osteotomy. So these osteotomies you can read, but this is the principle. And the third kind of osteotomy which we can do, we do not require in this patient in a small child, is the triple osteotomy, right? Okay. So the second one has been. Okay. Anybody who knows Bharti's disease? Okay. So Bharti's disease is nothing but it is idiopathic avascular necrosis of the hip, right? Now there are two methods to describe Bharti's disease. Number one method is descriptive method, and number two method is that how do we treat it, right? So there are two kind of classifications. One is purely descriptive, which will tell you that now the blood supply has stopped. Now the nucleus has become more dense. Now it has fragmented, and now after fragmentation it has started to repair itself. So this is Waldenstrom's classification. Do not confuse Waldenstrom's classification with the treatment. It will never guide you for treatment. What guides you for treatment is the classifications which will tell you whether the lateral part is involved or not. Right? Cattle classification or whatever classification you are using, don't get confused. They are just trying to tell you which part of the head is involved. Most critical part of the head is this, right? The lateral part. Here, the lateral edge of the acetabulum, it touches or articulates the head, right? There are the forces. This is the region where the forces, the weight-bearing forces are concentrated. So you have to see whether the lateral part is involved or. See, you can see the lateral part is involved. Okay. So what results in flattening and lateral subluxation? What results in flattening and lateral subluxation is number one. Whenever there is inflammation, whenever there is avascular necrosis, there will be inflammation. Inflammation will result in synovitis. Synovitis is, synovium is now occupying the space which was meant for the joint. So when there is synovial hypertrophy and there is fluid, what will happen to the joint? What will happen to the head? It will subluxate laterally. So it begins with that, and once it is laterally subluxated, inflammation does not come down, and the surgeon fails to contain the hip. It remains laterally subluxated. And once it has started, the forces from the acetabulum will gradually not allow this hip to come back, to contain, until unless the surgeon does it. Until unless the physician does it. Let me put it that way, because surgery is always not required. Right? So you have to imagine over here that there is a cartilage over here, a big cartilage, chunk of cartilage, which along with this bone is lying outside. What else is happening in this X-ray? This epiphyseal plate has stopped growing, but this epiphyseal plate continues to grow. So this results in coxa and because it is not congenital, it is called developmental coxa. That is another name for Bharti's disease, and this is the reason. Right? So how do we treat this? We know that there is lateral pillar involvement, right? How do we treat this? Once there is lateral pillar involvement, once there is subluxation. So what is the treatment? The aim of the treatment, what do we aim in Bharti's disease? We aim in Bharti's disease.
The containment of
Yeah, why do we want to contain?
the head with remodel.
Exactly. Because we want a spherical head. And what is the best method to achieve a spherical head? As I told you, this is a growing bone. Put it inside the acetabulum. Acetabulum will model the head and head will model the acetabulum. It is both ways, right? Now, can you put this head inside the acetabulum? How do we know that clinically? We know that clinically by examining this patient. So, to put this head back into acetabulum, what maneuver do we require? Abduction. So, you will examine this patient. If you see that there is free abduction, that means that this head has the ability to go inside the acetabulum. Acetabulum is not preventing the entry of head. However, most of the children who will come to us at this stage will have loss of abduction. Right? So, our aim is, before containment of the head, to achieve free abduction. And what are the methods to achieve free abduction? The method to achieve free abduction is, they are simple method, but we overlook them. You put the patient on traction, right? Prevent weight bearing for 2 to 3 weeks, put the patient on traction, and patient will regain abduction. If by this method, the child doesn't regain abduction, you have to apply Petrin's cast in progressive abduction and internal rotation, right? You do not operate the patient until unless you have free abduction. It will be a disaster, right? The patient will not gain anything. There will be further stiffness of the hip, and there will be the flattening of the joint will continue. All right. So our aim over here is to gain free abduction, so that we are able to contain this hip, right? So what method do you? Once free abduction is there, right? How do we maintain this reduction? There are two methods. Either you do it conservatively on braces, which is difficult, especially with a country like India, because braces have to change as the child grows and parents usually can't afford. And second, the child will not be able to visit his normal playing activities, visit his school, so it is difficult. So what do we do? The easier method is that you do a varus osteotomy, right? So if you are able to achieve free abduction, you do a varus osteotomy, and along with varus osteotomy, what else do you do? Because this physeal plate is continuous, it will continue to grow. So what you do epiphysiolysis of the lateral epiphyseal plate, right? So there are various permutations and combinations, but as far as this X-ray is concerned, we'll stop here. Okay. Slipped capital femoral epiphysis. Now, before we go on to this, this diagnosis should not have been written because it is important to interpret this X-ray, right? Okay. So since the diagnosis is already written, because once the diagnosis is written, we get biased. We stop thinking about the other conditions, right, which it can be. Now, let us see the normal head first, right? This is the acetabulum, everybody agrees. This is the femoral neck, this is the physeal plate, and this is the physeal plate, this is the femoral head, greater trochanter, lesser trochanter physis. Now, what is happening over here? Look at the acetabulum. Acetabulum is normal, right? The femoral neck, the greater trochanter and the lesser trochanter. Where has the physis gone? Do you think it is in its normal place? Subjectively, yes, all of us know it is not in its normal place. But what are the objective criteria? That it is not in its abnormal place. The objective criteria are that once you throw this line forwards, it cuts the lateral third of the physis, epiphysis, right? Over here, when you throw this line above, whole of the epiphysis is below or medial to this line. What is this line called? Pardon? Trichovan sign and line? Okay. Right. So, as far as the trichovan sign or Clamid's line is concerned, right, this will just give you an idea of the slip, that this has slip. But what kind of slip is this? For that you will require further imaging. So what image do you require for that? What do you require for that? A frog-leg image, but frog-leg will not be possible in a big child with a slip. So which X-ray you would cross-table laterally, right? Okay, so how do you classify this? So there are two kinds of classifications, and both the classifications they superimpose on each other. In Perthes disease, I told you two kinds of classification, they do not superimpose on each other, right? As far as management is concerned. Management is only by the second, on the form of staging, right? Over here, there is a temporal classification and there is a anatomical classification. Temporal classification means the time which has elapsed in between the slip and the presentation. And anatomical classification means the percentage of slip which has happened, right? So you have to take into consideration both the classifications before you start managing this patient. Alright? So I will not go into the details of management because it will be a big lecture, right? So we will not go into details of the management. You just need to identify that this is a slipped capital femoral epiphysis, and you should be able to identify, differentiate it from other common pediatric hip problems. Is there any other? Okay. So this is a case of, this is an X-ray of lower limb, of the knee, leg and the foot, and there is an obvious deformity which is present in the distal third of the tibia. Right? Now, I think all of you can recognize it to be a pseudoarthrosis, right? Which is congenital. So it's congenital pseudoarthrosis of tibia. You must remember, in congenital pseudoarthrosis of tibia, in adults, when there is non-union and fibula is intact, it is bad, isn't it? You will do fibulectomy. In a congenital pseudoarthrosis, when there is pseudoarthrosis, that means non-union, and fibula is intact, it is a good prognosis. When fibula is also involved in the pseudoarthrosis, that means both the bones are involved. The surface area of the bone is less. When only tibia is involved, fibula is not involved, that means that surface area is more, right? I am telling you about surface area because recently the guidelines about the treatment of CPT have changed. The guidelines are to produce union over a higher amount of surface area, because in a case of CPT, achieving union is not difficult. Any person can achieve union. You excise this pseudoarthrosis, you use whatever method you want, whether intramedullary nail or Elizorov, you will be able to achieve union. That is not difficult. What is difficult is to maintain this union and not let pseudoarthrosis happen again. That is more important. So if you will increase the surface area of union, the chances of refracture and developing pseudoarthrosis reduce greatly. And increased surface area will happen when there is vascular bone present. Pseudoarthrosis means avascular. Intact bone means a greater amount of vascular bone. So when more amount of vascular bone is present, that means you will be able to achieve more surface area of fibula. And that is why the principle of management of CPT these days is to achieve cross union in between proximal tibia and fibula and distal tibia and fibula. Whenever you are managing the case of CPT, please see that age makes a large difference to the prognosis. The smaller the age, the more invasive is the CPT, pseudoarthrosis, and more chances of recurrence. The higher the age, the better the prognosis, lesser the chances of recurrence. So, whatever I am saying might be contested, but as a rule, a small child with CPT should not be operated. You should try to delay it as much as possible, and you should try to operate these cases only after the age of 6 years, where it will significantly reduce. It is not as if it will disappear, the recurrence will disappear, but it will be able to reduce significantly. Okay. So what method will you use these days? What method will you use to achieve union? So you correct the deformity and you put in an intramedullary growth rod, right? And tightly packed with graft so that fibula, tibia, distally and proximally they cross unite with each other. Okay, next. Oh, thank you very much.
Yes? बोलिए ना read the Xray. Chronic osteomyelitis तो लिखा नहीं है उसमें ना क्यों कह रहे हैं chronic osteomyelitis?
एक्सटेंड विंडो पी क्या हो गया?
बोले why you say it is chronic osteomyelitis? On X-ray, on seeing this. You can see a sequestrum. Yes. The irregular thickening of the bone, yes. What is all this black thing? Sequestrum is which one? Outside or inside? Inside. Outside there is an involucrum. So why is the involucrum, what I was seeing this black area, what is that? Huh? How do you define a sequestrum? That bone? Your pus or unhealthy granulation tissue. So all that black is unhealthy granulation tissue or the pus. So the questions on X-ray viva can be in different ways. It can be either you can be asked directly what is the diagnosis, or you may be asked to describe the X-ray, and then ultimately it may lead to what we would do in this case. Both the ways it can be there. Either you start with the diagnosis or start with the findings. So suppose you got this X-ray. The next question will know what we would do. Causes. What causes? infection cause we know it is 95% or 99% Staphylococcus aureus infection. So what cause you want to know? Culture, yes, okay. What is that surgery known as? Saucerization. Saucerization is what is more important. Beads, one may agree or not agree. What we do, we have to open the cavity, remove the secustum, remove all the infected material there. So you have to have a healthy bleeding bone. And then, as you have created a cavity, the cavity otherwise will be filled with the blood and it might have some infection remains like that. So you have to eradicate that cavity. You have to cover that cavity. So what are the methods to obliterate the cavity? Cancerous bone grafting, when you are just removing the pus, it's not a good idea. It may get infected. Bone cement, antibiotic cement. No, but more biological thing which is available. Muscle plasma. That is the you mobilize a muscle from neighboring area and tap it there with make a drill hole and suture it, because whatever systemic antibiotics we are giving, they are going into the raceme only. So if area is vascular, then only antibiotics will act there. So that is there, and that will obliterate the cavity also, and then gradually the bone may build up. And when you are doing saucerization, make sure you do not remove more than 1/3 of the bone, circumference of the cortex. If you remove more of that, you may get a concussion fracture. That is also very important. Beads, yes, may be used when you feel that you are not able to eradicate the infection. Then you put beads. Otherwise, why you want to put beads? Or when there is a peri-implant infection, nail paint or joint, whatever, that is a very different thing. There you use beads more often, not for a simple osteoarthritis.
So when should we go for surgical? Should we give the patient antibiotic coverage for a certain time and then should we go for surgical management, or either we should directly go for surgical management with antibiotics?
When you are going to operate, you want to put antibiotics before.
I am just
How much?
asking.
How much before?
Should we give a antibiotic coverage and then we should go for surgical intervention?
No,
or
not necessary.
Directly?
Not necessary. You do give peri-operative antibiotics, yes. But pre-operative,
Before surgery, if we can give antibiotics, it might suppress the infection. So,
there is no use of that giving. You giving a pre-operative antibiotic for a certain period of time in this type of infection, which is having that picture. Yeah, there's something where it was just suspecting infection. That is a very different thing. Here it is established thing. There is a secustum, there is a cavity, there is a connection tissue, and giving antibiotic before and may not help. But yes, post-operative antibiotics must be there for at least 6 weeks. It's different from any other surgery. Okay, now we go to this. Which view is this? Which view is this? Yes? Good? The shape of the pelvis looks a little different from which you see usually. Yes or not? Huh? Why is that? Why it has happened like that? Probably this patient has got a fixed flexion deformity. So when he is lying on the Xray table, because of gravity the limb falls down, and so the pelvis tilts. That is why you are getting that view. So, as for others, as we said, either you go from peripheral to central or central to peripheral. Now, what things you want to see in this X-ray of pelvis and hips? So, any soft tissue swelling, not much here. Then, as we said, inlet view or outlet view or what view is there. When you do a PA view for the pelvis, sometimes you do posterior view also. When you want to see the sacroiliac joints, which is the ideal view for sacroiliac joint, is 35 degree oblique. Then it has to be done symmetrically for both hips, both sides separately, both sacroiliacs. So that which is maybe difficult sometimes. So the other view is a posterior view. That is for sacroiliac joint. When we take, when we can see both the sacroiliacs over. So here again you go from other areas first. You are seeing spine here also. You are seeing sacroiliac joint and hips and pelvis. So when we go to pelvic trauma, pelvic trauma, then you have many lines which you must know. What are the lines you draw, and in which you see which thing. If you the iliac oblique and obturator oblique views are there, what you see the anterior posterior column, the walls of the sternum. Now here what we are seeing, this line, if there is some bulge here, that is diffuse stuff, right? That will happen in bone softening diseases, which may be osteoporosis, osteomalacia, maybe rheumatoid arthritis, and many other rickets, many other things, and very severe may produce a tripodate pelvis also. Here you can see this ossification, iliosacral joint, iliosacral ligament is ossified, iliolumbar ligament. So, and sacroiliac on this side again you don't see very clearly, though it is not a view for sacroiliac, but still whatever you see. Coming to, when we see a joint as such, what we see? Comment in the joint. Joint is, you see the joint space, which is due to cartilage. The articular cartilage is there, which is giving you joint space. And the articular cartilage on both the sides is symmetrical. So that gives you a joint which is parallelism. The two surfaces are parallel to each other, the bony surfaces. Cartilage you don't see. There is a margin, then you see the joint margins. The margins, articular margins may be sharp or blurred, and they may be regular or irregular. They are two different things. It may be sharp and irregular, they may be sharp and regular, both. Similarly, a blurred or fuzzy margin may be also be regular or irregular. So, you see the margin here, the margin is not very sharp, but still the margin is visible and it is regular, it is not irregular. Though the joint here is different and joint here is different, so you cannot compare because this joint has got something very different. But otherwise, you compare with the opposite joint, whether joint space is reduced or not. Now, what you are seeing on this side? Here, it seems the space is not there. You don't find any joint there, and you see some trabecules which are going across. So that means there is a bony fusion here. Once the joint gets bony fusion, then the trabecule becomes continuous to some opposing surfaces. So here you see the joint space is absent and the trabecules are going across. You see this bone formation here also. That means the joints of the hip, ligaments of the hip joint are also ossified in this area. And here also there is some sharpening, but the ligament is not ossified. Then you see what osteoporosis in the bones, the neighboring bones. Here you see the relationship between the cortex and the medullary canal. And you find the cortex here is thinning out. So there is osteoporosis also in this. So what will be the diagnosis here? Yes? Ankylosing spondylitis. Most likely, because it is involved, spine is involved, and sacroiliac are also involved. Most probably it is going to be ankylosing spondylitis. Okay. It's a different one. Now here again, you see, say is not very clear in this area, but if we see the confine of hip joints only, what do you see about joint spaces here? Yes. What do you say about joint on the right side? Reduced joint space, yes. Margins irregular. Which margin? Acetabular margin or femoral margin? Acetabular margin. That is, acetabular margin here is irregular, but it is sharp. Then what is this? Yeah, osteophyte formations is there. Yes. What else? What is on this side? Space here also seems to be reduced. Now again, here it is a bilateral disease, so you cannot say. Otherwise, you have to compare with the normal side. But it seems that probably this is also reduced. What else? What is this? What this line you are seeing here? What is that? You don't see that normally in naked X-rays. Sagging rope. No, I don't think that. Sagging rope line is somewhere like this. This looks more like a capsular calcification or osteophyte on the acetabular margins. It is overlapping. You see here also? Something like that is happening here also. So, what will be the diagnosis? Avascular. Why avascular? You don't see anything in the head? Not much. Avascular tuberculosis, bilateral, degenerative osteoarthritis. That's a simple thing. Yes? Hello? बोलिए बोलो भाई read the X-ray.
That's plain X-ray of pelvis, both hip and spine. The left side there is a hip joint. Joint space is not.
ऐसे देखो.
The joint space.
Joint space.
On the left side joint space is diminished or not present.
Not present. Okay.
Seems to be some the femoral head margin is not visible. So there's an ankylosis.
Okay. Next person was he also speak. आप कुछ बोलना चाह रहे थे बोलिए. हाँ? What is the main thing here? ये क्या है? हो गया एक चीज और अभी की बात करेंगे सेपरेट बात करेंगे और बोलो एक तरह का अभ्यास जो बस चीज का दिख रही है आपको सबलक्सेटेड what has happened to the first thing जो उन्होंने कहा joint space reduced. Do you agree? Okay. Is the acetabulum normal? What has happened to acetabulum? Widened and deepened also. This is widened, this is widening, this is deepening. You see that trochanter is almost averting. You see the distance from trochanter to it? So it is widened and deepened and head has gone up. You see a break in the Shenton's arc. This is the Shenton's arc. You go along the neck and it is here. So here it has migrated up by about an inch. And joint space is almost absent. You don't see whatever the quality of X-ray, we are not seeing well whether something is there, but there is it doesn't look like bony necrosis. That is what I am saying. If you see clearly, there is some joint space here, and there is some sclerosis occurring here. You don't find much osteoporosis in this area. In this X-ray, quality of X-ray may be bad, but what is visible. So, and the acetabulum has gone up. So, what do you think about that? Why TV? Why TV now explain? You are right, but why? Huh? Back, please. बोलिए क्यों? Widened acetabulum हो गया है. अच्छा, is it same as wandering acetabulum? Is it wandering acetabulum or not? Is it wandering acetabulum? Classically described for tuberculosis? No, it is not. In wandering acetabulum, it is the superior margin of the acetabulum which is destroyed. And it slides over it, wanders over it. Here it is gone deep. It is not wandering acetabulum. Deep protrusion is there and it is a deepened acetabulum, it is not wandering acetabulum. So probably it is a fibrous ankylosis there, because sclerosis occurring there, so it is a long-term thing. It is not a fresh case. It is an old case of tuberculosis which has healed by fibrous ankylosis most probably. There is overriding, there is shortening, and there's all the user etc. there.
Are you saying sacroiliac joint and lumbar spine, sir?
The quality is not very good. I don't think sacroiliac should be commented on this aspect. Here you are seeing the soft shadow. There are certain other lines here. Sacroiliac, I will not comment on this. You know, sir? Sacroiliac?
We should not comment.
I don't think we should comment on that.
Sir, is a classical case of tuberculosis. Almost getting into the faster mortality. थोड़ा सा
Head size is not that small. Head size is not that small. Say western model. You are aware of the types of acetabular picture in the radiological classification of Shimukha Sundaram? Huh? Are you aware of that?
Yes, sir.
This is what.
the same tuberculosis one can see in the same festival.
This is fractal model appearance. So the head has become like a small one, like a fractal. This is fractal model appearance. Here you see her fuzzy margin. Margin is irregular and fuzzy. And here you see the head has been destroyed highly. So you see in the other previous one, the external destruction was much more. The head size has not reduced. Here the head has been involved much more, even though acetabulum is involved, but head is more involved. And here again you see deepening but not protrusion. So acetabulum is not that involved. Again, but the superior margin is there. So again it is not monitoring acetabulum, it is monitoring cluster type of appearance. Anything?
tuberculosis, healing, either healed or
What is this here? What is this? White thing. Line.
discussing this scoliosis case. No?
अभी बात
You have to see.
This is Reiser's sign. Yes, this is Reiser's sign, which you see for maturity of the skeleton. And as was said, that once it is fused totally, then scoliosis progression will be halted. It will be minimal only, say about 1 degree per year. But before that, it may be about 1 degree per month. So, further off, the same thing probably. Again, you see the same mortal plaster type thing. This is the neck. Head has been mostly destroyed. Irregular margin of the acetabulum. Shortening is not that much here. You see what this part of destroyed head here. So here you are seeing the lateral subluxation. You see here, it is not going in this direction. The head is going in this direction here. And this is one, if remains like this in future, this may go to wandering acetabulum. Here it is going on the lateral side, on those ones it was going on the medial side. But again you see subsclerosis, the articular margins are destroyed, irregular, fuzzy, and overriding of the trochanter. Trochanter has gone to the neural superior margin of the acetabulum. Normally it should be at the center of the neck.